the lungs and helps the patients be more likely to get over the ARDS. You also support them generally with fluids and nutrition. And a big problem in ARDS is that patients can go on to develop a ventilator-acquired pneumonia, and this is often life-threatening. So what I'm going to do for the rest of this module is talk about some specific pneumonia bugs that have unique features you need to be aware of. And the first bug I'm going to discuss is Legionella. So Legionella was first identified at an American Legion convention where there was an outbreak of pneumonia, and that's how it gets its name, Legionella. The infection is caused by inhaling aerosolized bacteria in water vapor. At this convention, there were bacteria in the water vapor in the air conditioning system, and that's how people got sick. So it's not that the bacteria gets airborne, it's that it gets aerosolized. And if you know the history of how this bug got its name, it helps you to remember that it causes outbreaks at hotels with contaminated water. And in fact, that's a classic way for it to be described in a board question. It can also cause nosocomial pneumonia in nursing homes if it gets into the water system there. So initially, Legionella causes a mild pneumonia. Remember that it's one of the atypical pneumonia causes, and those atypical or interstitial pneumonias are usually milder. So these patients may have a fever, but they'll have mild, slightly productive cough. It can progress to a severe pneumonia in some patients, especially elderly patients or patients with comorbidities. And two special features of Legionella pneumonia that you should know about are the GI symptoms and the low sodium level. So patients with Legionella often have concomitant GI symptoms like watery diarrhea, nausea, vomiting, or abdominal pain, and that makes this a unique bug in terms of pneumonia causes. In addition, patients with Legionella classically have hyponatremia. They can develop a sodium level that's less than 130. Now, in reality, any pneumonia can cause hyponatremia, and hyponatremia is very common in the hospital in patients with pneumonia, but it's more common in Legionella, and if it comes up on a board question, it's most likely going to be from Legionella. Legionella has special culture requirements. It does not gram stain well. One of the media that's often used is called buffered charcoal yeast extract. This has iron and cysteine added, which helps the Legionella to grow. It's also supplemented with a couple of things, antibiotics and silver dyes, and these prevent overgrowth of competing organisms, and the dye also gives a distinctive color to Legionella. Now, because it's so hard to culture, often a culture is not done, and there's a urinary test. It's called a urinary antigen for Legionella, and this lets you know in a few minutes if the patient has been exposed to Legionella. It doesn't test for all Legionella subtypes, however, so just because the test is negative doesn't necessarily mean the patient can't have a Legionella pneumonia. So the classic case is a patient with a mild cough and watery diarrhea. The patient may have confusion from the low sodium level, and there'll be negative bacteria on gram stain because, as I said before, Legionella doesn't gram stain well. You can diagnose it with the urinary antigen test, and then the antibiotics that are usually used are fluoroquinolone or azithromycin because both of these antibiotics cover atypical bacteria. Besides Legionella pneumonia, there's another infection Legionella can cause, and that's called Pontiac fever, and this gets its name because after they discovered Legionella at the American Legion Convention, there was another outbreak caused by Legionella in Pontiac, Michigan. This is a milder form of Legionella infection. Patients will have fever and malaise, chills and fatigue, typical infectious symptoms, and usually a headache. But importantly, they won't have respiratory complaints, and the chest radiograph will usually be normal. Next bacteria we'll discuss is Mycoplasma pneumonia. This is another atypical pneumonia, and you can't see Mycoplasma on gram stain because it has no cell wall. This classically causes outbreaks in young adults, so you'll see description of outbreaks in a college dorm, for example, or in a military base among recruits. Like with some of the other interstitial pneumonias, the chest x-ray can look worse than the symptoms, so the patient can have mild symptoms, but a chest x-ray showing lots of interstitial inflammation. And two special things to know about Mycoplasma pneumonia are that it can cause anemia and skin disease. So the anemia is an autoimmune hemolytic anemia. There's an IgM antibody produced from infection that attacks red blood cells. And this is an example of a cold hemolytic anemia. There are both warm and cold anemias, and this is a cold one. And then in addition, Mycoplasma can cause Stevens-Johnson syndrome, which is a life-threatening skin infection where the epidermis separates from the underlying layers and you get desquamation of the skin. Influenza virus is another cause of atypical pneumonia. There are two viruses, influenza A or B, and when you get the flu shot every year, if you do, it's to try and prevent infection with this virus. There are a lot of non-specific symptoms to influenza infection: fever, headache, myalgia, malaise. In addition, the respiratory symptoms that people get are a non-productive cough and a sore throat and a runny nose. And the major complication of influenza virus that you should know about is a secondary bacterial pneumonia. So as people are recovering from influenza virus, they're vulnerable to a secondary infection with a bacteria that can be life-threatening. Bacteria that like to do this are Strep pneumoniae and Staph aureus and H. flu. And the classic history of this is a patient who's recovering and then gets worsening symptoms after they had an initial improvement. And this is the reason that people die when there are influenza virus outbreaks. It's not the virus, it's the secondary bacterial infections that people develop. Cytomegalovirus is a very rare cause of pneumonia. It causes pneumonia in transplant patients on immunosuppressive drugs. And the one thing to know about cytomegalovirus is the owl eye intranuclear inclusions. This is an example of it down here. So the dark stuff inside this cell here is cytomegalovirus material, and there's a little clearing around it which gives it sort of a halo, and this is described as an owl eye intranuclear inclusion. And that's what you see in tissue samples of patients who have CMV pneumonia. Respiratory syncytial virus is called RSV, and this is an infection that occurs in infants and children. The outbreaks are usually seasonal, so they happen in the winter months between November and April. If you do an inpatient pediatric rotation in the winter months, you will see many children hospitalized with RSV infection. It's the most common cause of lower respiratory tract illness in children. It causes a couple of different problems. It can cause bronchiolitis, which is inflammation of the bronchioles. It can cause pneumonia, and it can cause acute respiratory failure. It often starts as an upper airway infection, so the child will have a runny nose, and then a few days later they start to get lower tract symptoms, especially wheezing. Because like I said, it often affects the bronchioles, and this causes narrowing and leads to wheezing. There are two treatments for RSV that you should know about. The first one is a drug called ribavirin. This is a drug that inhibits synthesis of guanine nucleotides so that the virus can't replicate itself. The second drug is used for prevention. This is a drug called palivizumab. This is a monoclonal antibody against something called the F protein. RSV contains this surface F protein, and the F stands for fusion, because it causes respiratory epithelial cells to fuse as one of its pathogenic mechanisms. And this is sometimes used in preterm infants who are at very high risk for RSV, sometimes also given to children with congenital heart disease who could have a life-threatening infection if they get RSV. So the classic case to recognize for your boards is a young child, usually under 2 years old, who has fever and a runny nose, and then a few days later gets cough and wheezing. This may be a case of RSV. Next, let's talk about aspiration pneumonia. So this occurs when patients aspirate microorganisms, usually from the oral cavity or the naropharynx, into the lungs. So what type of patients would aspirate oropharyngeal contents into the lungs? Well, patients who have reduced consciousness, for example, if they've undergone anesthesia, they can't protect their airway and they can aspirate. Patients who have seizures can aspirate into their lungs. Alcoholics can lose consciousness and aspirate into their lungs. And then finally, people with dysphagia for any reason. So this commonly occurs in very elderly, frail patients, but it can also occur in people with ALS or myasthenia gravis who have neuromuscular weakness. Classic aspiration patients are debilitated nursing home patients or alcoholic patients. They can aspirate contents into their lungs. So the bugs that tend to cause these aspiration pneumonias are Klebsiella and Staph aureus, and then lots of anaerobic bacteria. These normally are present in the oropharyngeal cavity, so when you aspirate, you sweep them into your lungs. These are bugs like Peptostreptococcus and Fusobacterium and Prevotella and bacterioids. And the first-line therapy for aspiration pneumonia is clindamycin because it covers all those anaerobic bacteria. Klebsiella pneumonia is a rare cause of lobar pneumonia. When people do get it, it's often from aspiration. It's a very serious pneumonia. It causes marked inflammation and necrosis in the lungs. And it classically causes a thick mucoid and blood-tinged sputum to be produced, which is described as currant jelly sputum. And don't confuse this with currant jelly stool, which is a description of the stool in patients who have intussusception of their bowels. Next, let's talk about lung abscesses. These are contained fluid-filled spaces in the lungs with an infection. And the way they're described in a question stem is as showing an air fluid level on imaging, usually chest X-ray or chest CT. What happens is you get a walled-off area of infection, and there will be fluid and pus drawn down to the bottom by gravity, and it will create this appearance of an air fluid level, which is this line I've drawn right here inside the cavity on imaging. Lung abscesses are usually a consequence of aspiration. Rarely they can be caused by bronchial obstruction from a cancer. The bugs that cause these are predominantly anaerobes, and that's why they come from aspiration. You aspirate those anaerobes in your mouth and oropharynx, bugs like Peptostreptococcus and Prevotella and bacterioids and Fusobacterium, and those lead to the formation of the abscess. Sometimes Staph aureus and Klebsiella are also involved. And the treatment for these is the same as treatment for aspiration pneumonia. It's clindamycin. However, if the abscess is big enough, sometimes it has to be surgically drained. The final cause of pneumonia I'm going to discuss is pneumocystis jirovecii, which used to go by a different name whose initials were PCP, and it's still often called PCP pneumonia. This is a diffuse interstitial pneumonia that requires immune compromise, classically HIV. This is considered an AIDS-defining illness. So a little bit of history here. When AIDS first developed in the 1980s, healthy homosexual men began to present to their clinicians with PCP pneumonia, which had previously been very rare, and tumors called Kaposi sarcoma, which also were very rare. And as people began to work up the reason why these healthy young men were developing these rare conditions, that led to the discovery of the AIDS virus. PCP is a yeast which gets inhaled, and it usually causes no symptoms whatsoever if your immune system's intact. But if you have HIV and AIDS, you can get pneumonia from this bug. The way you diagnose PCP pneumonia is by looking for the yeast under the microscope. You either need to take a sputum sample or a bronchoalveolar lavage sample, and you can't culture this, so you have to stain it, and there are special stains required, and they all use silver. And what you see when you look under the microscope is something like this picture down here. Just remember this picture because this is a classic example of PCP. And the silver stain makes all the PCP bugs look dark black, like all these little circles that you see in here. These are the cysts from pneumocystis, and this is what it looks like under the microscope. The first-line therapy for PCP pneumonia is trimethoprim sulfamethoxazole, or TMPSMX. It goes by the name Bactrim. There are also some second-line agents that are sometimes used, like dapsone and pentamidine. And we do often prophylax people so that they won't develop PCP pneumonia. Bactrim is given to HIV patients when their CD4 count falls below 200. And Bactrim is also sometimes given to patients who are on high-dose steroids or other immunosuppressive agents so that they won't develop a PCP infection. And that concludes our module on pneumonia.